This is the Equity Charter podcast, where we talk about why we care about equity in the digital health sector and why we think you should too. Welcome to this week's episode of the Equity Charter podcast. My name is Aisha Rahim and I'm a psychiatrist and Chief Clinical Information Officer working in the NHS. Along with my colleagues Hassan Chowdhury and Victoria Betton, we developed 10 principles for embedding equity within the digital health sector. This week, we'll be looking at Principle 6, which is equity embedded in research and innovation. And here to discuss this topic with us today, we have our two experts, MaryAnn Ferreux and Jess Morley. Welcome to the show, MaryAnn and Jess. Thank you for joining us today.
Thank you for having me.
All right, so I think we'll just start off with asking you both a bit about yourselves and your role. So if I start with you, MaryAnn, can you say a little bit about what you do and about your role generally?
Yeah, thank you. I am a medic by background. I originally from Southeast London, but trained up in Liverpool. I've got a portfolio career now, so I work for the Health Innovation Network. I cover Kent, Surrey and Sussex, and I'm their Chief Medical Officer. I also have a couple of other roles, so I'm a non-exec director of two NHS trusts, a community trust and a mental health trust in Kent. I live in Kent, so for me it's really important to be able to give back and contribute to the health of my local community and just have a real passion around health equity and EDI, and particularly in the space of innovation and research and the future, and making sure that everybody's included and counted right from the start in terms of what we design and develop around that space.
Thank you. And same question to you, Jess.
Yeah, so thank you so much for having me. It's great to be here and have this conversation. So right now I am Associate Research Scientist at the Yale Digital Ethics Centre. I've been here for 2 years. We are a research centre that does research essentially on how do you design a good digital society, and I run our health pillar. Before I was here, I was in Oxford for a long time. That's where I did my PhD and my master's. I also worked for what is now the Bennett Institute for Applied Data Science. But when I first joined, it was the Data Lab that built the UK's largest electronic health record platform, Open Safely, if anyone's heard of that. And then before I was in academia, I worked for the civil service. I worked for the NHS, very originally as an NHS analyst, and then worked in various iterations and then in the Department of Health. And I would say in my overarching research goal and aim of everything that I do, especially now, is about how do we achieve this sort of double bind problem with the use of health data research? How do we use it to both simultaneously solve some of the problems that we know exist with regards to health equity, but at the same time ensure that they don't exacerbate those existing issues or indeed create new ones? And so everything I do is sort of wrestling with that question.
Thank you. Okay, so let's start really basic then. Why do you feel equity is important in the research and innovation environment? And, what do things look like when these elements aren't considered?
I mean, for me, I think it matters enormously, especially in the context of somewhere like the UK, where basically we have a values-based healthcare system. If you take out the values that underpin the NHS, you essentially take out the NHS. But even if you take away that and you go much more meta and you just look at a human rights perspective there, that first one is in there. Everybody has the right to health, right? That means everybody has the right to health. And that means everybody in all contexts. We're not talking about just age or ethnicity or sex or sexual orientation or jobs, like everything all in one go. So I suppose it matters most because of that. Then just purely from a pragmatic perspective, health is relational. I think we often talk as if, and we're very used to assuming that health is something that affects only us as individuals, but that's not really how it worked. COVID really proved that to many people. All of our health is reliant on everybody else's health that we interact with. And so if you don't raise everybody up, you are essentially decreasing everyone at the same time. So it's really important from that perspective. And then in terms of what does it look like if it's not included in health and care research. Exacerbation of existing inequalities. So everybody knows, presume anyway, that the healthcare itself has traditionally not been very equitable. We might aspire to get there, but we're not. And there are a wide variety of reasons as to why that happens. Now, health data research is a phenomenal tool to close that gap, but it can also make it significantly worse. And that's what happens if you don't sort of bake it in right from the start. And sort of the things that you might start worrying about is like increased stigmatization of different groups, or people being ignored or made invisible because they're not included in research.
Yeah. I think I sort of start from a place that's more sort of in the lived experience, I think. So I've been a medical director for, 11 years, something like that, 11, 12 years. And I think early on in my career, I didn't really think about it. I didn't actually really think about health inequalities or health equity that much. I think it was really after George Floyd and COVID that I started to realise. So for those that can't see me or don't know me, my background, I'm a woman of colour. My background, my dad was Nigerian, my mum's English. And although race has played a role in my life and in my career, I don't think I really realised the impact of it until those kind of two quite significant moments, and at the point I was at in my leadership journey as well. And that really brought me face to face with quite a stark reality of inequalities existing both in health, but also well beyond health and more generally across society, and how deep-rooted some of that was.
So you both made reference to the differential health outcomes, which we know that the data for this is unequivocal, really. Do you see this translating into research that's taking place now and innovation that are targeting interventions for underserved communities? And, you know, where do you see the biggest gaps are that should be targeted?
I mean, so obviously it massively translates into research and then increasingly now into development, because that's also where we are with the arrival of AI and app-based health. They sort of view that line between what is purely sort of academic research, what is service analytics, and what is innovation and development is sort of blurred in quite an extreme way. And the way it impacts is sort of a multitude of ways. First of all of the things that we've just been discussing in terms of the inequities and outcomes that already exist, they therefore exist in the data. And so everything that you do on research is basically based on data. Any of those sort of developments or innovations that I just described are also based on the data. So you're going to learn, if you're an algorithm, the patterns that already exist. And if those patterns are inequitable, you're going to repeat them. And we see this happening. We've seen it happen lots of times. There's a very famous study that looks by Obermeyer, for example, which is looking at a risk prediction algorithm in terms of looking at risk stratifying who is going to be most needing of care. And what it transpired was that the algorithm or the piece of research had essentially learned to conflate billing and cost of billing with access and therefore need. So it was systematically underestimating the level of risk of people of colour who have traditionally had less access to the healthcare system, and it was assuming that they were at lower level of risk even if they were at the same level of sick. So we see that happening again and again and again. There's also a problem in that things are harder to see. There are some, and this was to MaryAnn's point in terms of intersectionality, there are some biases, which is really what we're talking about, in data that are kind of obvious and you can go looking for them. So I can go looking to see if my data set is representative from the perspective of ethnicity or gender or anything like that. But when it comes into stuff that is proxied, so it's inferring from other things and it's inferring from when things are joined up, it's very hard to see, and we don't necessarily know whether those inequities are there, and then we don't know how they are magnifying in terms of things happening over time. And then there's this fact that they get perpetuated into outcomes. If you've got people who you're, say, for example, that example I've just given you, you're under-predicting the risk of a group of people, that ultimately means you're going to have inequitable outcomes that were starting from an inequitable base, and it's going to widen. In terms of where there are opportunities to make things better, the other way of looking at this is we can look at this as a problem, but we can also look at it as a diagnostic. Okay, so we can also go, right, so we have all of these things and them underperforming for this particular group of people, or we've looked at the data set and it's non-representative of this particular group of people. We should figure out why so we can fix it. So in some ways, it's actually a very helpful tool for helping us diagnose where there are flaws in the system that we can go back in and fix or think about what do we need to do in terms of that. It's also a pretty good and powerful way of getting to this difference between equality versus equity. Equality is everybody being treated the same, and equity is giving people what they need in order to achieve the same outcome. That's very difficult to do based just on human cognitive capacity. When we can model it, and there are a wide variety of techniques now that exist in research and modelling, we can get way more into the weeds of what that actually means. And so there's also an enormous amount of opportunity to make things better in those kind of dynamics.
That's such a fascinating point to me that I hadn't considered, actually, is how the bias that is being shown through these algorithms actually prompts us to do some thinking and do some work in areas that perhaps we wouldn't necessarily have considered had we not been shown the bias, I suppose, through these algorithms. So that's a really interesting point.
I think that for me, as I sort of was trying to get to the point of going through that lived experience and becoming aware of these biases are not just things that I think happen in the system, how baked into the system and our structure they really are, really made me start to want to know more and then want to ask more questions. So I had a lot more curiosity, because I don't think I would, for example, things around gender bias, things around racial bias, even just medical practice, I had no idea. I blindly was just getting on with my life, if I'm going to be honest. So I think there's something about now I sit on boards, I speak to leaders across the system, to lots of decision makers, and they're also going on this same journey of awareness. So I think we are moving now into a space where people are more aware. But again, I think there's so much to learn, because what's happening is that I'm seeing lots of decisions get made, which is what sort of Jess is talking about, where people are not taking that baked in bias into account, probably doing what I was doing before, which is just kind of getting along with things and thinking, oh, everything will probably work out, and not thinking about that equity piece, which is, what could I be missing? Who am I missing? Who's this benefiting? Who's missing in the data? I wouldn't have probably have thought to have even gone looking for that type of information. So I think that, in particular around innovation and the work that we're doing around supporting innovators around equity and how they think about equity, we're going right back to the basics. So yes, it includes the data, what's happening in the data, but actually it's trying to spark curiosity to ask some questions around other people that are within the community. So if we've got the most underserved, marginalised group, how might they use your solution, your digital app? What might exclusion look like to them? And I think we're doing a lot more around patient and public involvement and engagement, but I don't think we do co-production and co-design very well. I think what we do in health has often been quite piecemeal, and we've designed something and then gone back and asked the community, what do you think? We haven't really gone through that much more participatory process to really actively engage them right at the beginning. So rather than being an afterthought, and we'll add that on afterwards because it probably doesn't matter, really going right at the beginning and saying, no, it does matter now. Let's make sure that everybody's included from the beginning. And for us to be able to do that, I think we have to start having really honest conversations with people, and sometimes it's uncomfortable. Let's be honest, the current climate around some of the topics that we're talking about and I'm conscious, Jess, you're in America, can make it really challenging to even say EDI or DEI. So if we can't even mention the words, how can we move this forward? Because, how I start to talk about it now is there's actually an economic imperative that we get this right. Health inequalities is costing the UK £30 billion a year, and 5 billion of that is within the NHS. So we can't afford not to do something in this space. And I think that we've all got to sort of come together around it as a collective problem, because it's pervasive, as Jess has said. It's in the research, it's in data, it's within, many of our policies, governance, structures, workforce, it's everywhere, and we need a really collective response to do something about it.
And the journey that you've been on, MaryAnn, feels like it resonates with me quite strongly, because also as a doctor, I think back to my medical school days and thinking about my dermatology lectures, which were only taught to me on white skin. And, I'm a woman of colour also, but it didn't even occur to me. It was just it felt like the default setting. So why would I question it? And I've also been on a very similar sort of light bulb turning on moment, which has influenced me.
Yeah, and same with, things around women's health. Back in medical school, I think we might have had, half an hour on menopause. I don't think we really did anything on it, yet alone understand, the connection with cardiovascular disease and mental health. I think that there are so many things we've perhaps overlooked and taken for granted that kind of need to be undone. And I think there does need to be a structural response to that. I think yes, individuals can each do their part, but actually the system needs to make some fundamental changes to ensure that, for example, within clinical trials, it is like 50% women are on those trials, and it's not just sort of white men of a certain age who participate. So a much, more diverse set of people contributing to that data.
Yeah, and that's something I'd like to explore a little bit more, actually. So I'm really interested in what levers we have to encourage this equity conscious approach. And I'm just wondering if either of you had any thoughts around that.
So, I think really MaryAnn already mentioned the word co-design, but basically all of this sits within design. I think we have all of the levers because we are in control. The problem comes when people assume that it's something that's like inevitable and thus we cannot change it. It's like, well, no, we can. We created the system that's a problem. That means we can directly change it. And, we can think that through in terms of data. You can think about it so we should probably be setting standards with regards to what data sets are available to use when you are doing health data research, and especially when you're doing development. Often the way in which that gets talked about is the assumption that more is more, right? Mm-hmm. So often you see it in policy coming through and it will be like, oh, we want to get more data sets. We want to get more data sets. So that, no, because what we have right now is thin but wide, and what we actually need is deeper data on and more a range of people. And so what I actually think we should be doing is defining minimum standards of data. So we must say that of all requirements, they must as a minimum have X, Y, Z. It's a bit more like the minimum viable product is the minimum viable data set. We don't do that. We just assume that we need to create more. Then you can do the same thing in terms of design templates for anything that you are looking at with regards to apps. A really, really simple one is if you go on most triaging apps, the first question that they will ask you is, are you a man or a woman? There's no reason to ask it that way. What they want to understand is, should I be looking for diseases and ailments that are more affiliated with assigned female at birth organs or assigned male at birth organs? That doesn't mean that the first question I have to ask is, are you a man or a woman? So we can start thinking about design patterns in that way in terms of making them more inclusive. And you can also think in terms of service and pathway design. So to talk about MaryAnn's point in terms of exclusion, we probably still, in most instances, need a digital and a human path. And digital exclusion is not just, does the person have a latest device? It's far more insidious than that. If you can look at it really from an exemplar of the LLMs now, that everybody's using ChatGPT or Claude or whatever. First of all, not everybody has the paid version. So you have different access to different levels of models. But it also, their responses vary hugely depending on the way in which people interact with them. And that is entirely predicated on people's level of literacy, and specifically their digital health literacy. So that is a whole nother world of digital exclusion that I don't think we've even come close to thinking about or touching on. So those are all soft levers. And then we also have harder levers, which is where you sit in terms of regulation. So, if you're talking about algorithms and AI, we should be doing far more in terms of regulating with regards to validating. So right now, there is very few requirements to say, test this and ensure it works representatively. Or if you know where it doesn't, make that transparent. I think that's one of the things that sometimes people say to me, or what you're trying to describe is a perfect situation. I'm not. We're never going to eradicate bias. We are never going to eradicate any of these things. They are going to always exist. What we can do is get better at acknowledging that they're there and make sure that there are things in place to try and mitigate the consequences. So it's basically about pulling those kinds of levers all the way from soft levers through to hard levers through different parts of the pipeline, right? From data collection all the way through to implementation and what you do in terms of monitoring things once they've gone. But the biggest takeaway message is we are in control.
I would agree with Jess. I mean, I guess on most things, I believe that you need a stick and a carrot. I think we do need a bit of a stick on some of this, because I don't think people will shift unless they are made to on some certain elements. I guess an example of that could be looking at health and ethnicity data and how poorly it's filled in, and the understanding of the complexity that sits around ethnicity and why it's a hard one for clinicians to ask the questions, and it's even harder for a patient to answer the question. And the trust or lack of trust within the establishment that sort of sits behind that whole question. Sounds so simple, but actually really complex. And I think unless there is a bit of a stick that says, no, that needs to be filled in, and obviously from my perspective, if we can support individuals to fill that in themselves, that to me is going to be the most accurate representation of, their ethnicity. I have seen patient records where one individual I had 5 different ethnicities recorded. I don't know how that's possible, but I have spoken to clinicians that apparently filled it in for them without asking the question. So the data around that is not clean at all. And I think a bit more thought needs to go into an approach around that. But again, until recently, we didn't really have a stick around that. It didn't have to be filled in, yet we were expecting people to be able to report on it, talk about addressing health inequalities through Core 20+5, all of these other elements without some really key parts being in place within the system to monitor and measure that. So I think that's definitely really important. I spent a lot of time, many years, trying to convince people of the moral argument to do something. And I've realised that on some people that does work, on many it doesn't, particularly in leadership. The levers for change are often sat within financial rather than in a social justice space. And so, I think it's up to us as leaders to change the narrative, which is, if that's what ticks for them, how can I reframe it to fit what you need to hear, if that makes you do the decision? I don't really care how we get there, as long as we get there. I'm not precious about who does what, but I do need people to action things. And then just finally, one thing that I think we really need to address is the leadership. Who is in the room? How diverse are those people in the room? I mean, it's fantastic. We've got a call here with 3 amazing women, but the reality that I sit in is there aren't enough women and there are very few people of any colour. Yet we're forming these echo chambers of decision making that happen. So we're not going to get the right policies that come through unless we start to think about the leadership and the leaders that are in the room and increasing the diversity that's at the decision-making table.
Yeah, I think that's a really important point, isn't it? And I wanted to pick up specifically on the financial question, really. What do you see as the role for funders of innovation research? And I'm thinking particularly in the UK of organisations like the National Institute for Health and Care Research, the UKRI. Is that something that is underutilised as a lever for change in this space?
Massively. From a research perspective, they are the main way in which research gets done. And in actual fact, one of the main reasons why the UK has such phenomenally competitive research is because we have competitive research funding. And so it's basically the main way in which you can try and accelerate change. You know, you put out a big call for a specific type of research, then people will go, oh, okay, actually, this is something I need to pay attention to because I can get money for it. But it's not just about doing that. I think there are different ways in which funders can play, right? So you can put out, like what I'm talking about, a big specific call. We want to do a call on data curation with regards to equity. So what are the minimum viable things that I was talking about, but also can you do an assessment of how ready is the UK data for this perspective? But you can also build it in to everything else. You know, I sat on a funding call as one of the assessors for a while back. I won't say which funder or which call, but one of the things we were looking at was where's the money going? And if you've got across a multiple of different institutions, including institutions that are in LMICs or that work with populations that are not the sort of mainstream, you can immediately see if they're saying these are people who are partners, but that they're only getting like a 5% of the funding, then you can call that out. The funders can say this is not okay. We want the funding to go to here. And it's also in terms of how you monitor the outcomes of research. You know, research has this slightly antiquated problem with publish or perish, where basically your main metric is have you published in a journal, which journal did you publish in Nature or the Lancet, or and how many times that gets cited. That's cool, and I'm a data head and I love that type of thing. It is entirely irrelevant to whether or not you've actually made an impact. And then the way in which universities get scored is on the ref, which is basically have you made an impact, and that again tends to be in these very quantitative types things of did your research get cited in a particular policy document? Then you can go and say that. But it would be far better if you could say, okay, well, can we actually track what happened as a consequence of the thing that you found, and were you contributing to a problem that is significant, especially for this particular group of people? And that flows all the way through. So you can do it in multiple different ways. Like if you're talking about funding a project that was algorithmic development, for example, then the funder can say, I don't really care about your statistical accuracy level. I don't care about your AUC value. What I care about is whether or not you think that this is something that's going to deliver meaningful change in terms of outcomes, and especially in terms of equity. So they have an enormous amount of power and therefore responsibility, I think, in this space. And you can tell, I mean, MaryAnn made the point about me being in the US. That's the lever that the current administration pulled. Was they were like, we don't like this, so we'll make a list of words that are banned from research. Yeah. One of them being bias, and one of them also being woman, and they are aware that's the lever of which you can pull to change things. So if they can use it for negative purposes, we should be able to use it for positive purposes.
Yeah, I'd agree. Innovation's very similar. So, the likes of UKRI, Innovate UK, very large funding pots of money, large grants, and hence why I talked about changing our narrative to where the levers are. I think that's really important, because I don't think there will be change if we just leave it how it is. I think it's very, to change something takes effort. So, we're going to have to make an effort to do something different. And there'll be winners and losers. So I talk about this quite a bit around equity. some people have been doing pretty well out of it. Some people haven't. But to redress the balance, it's going to be painful for some people, and they might lose money and they might lose resources. And how do we communicate that and take people through on it? Because that's the jarring point, isn't it? That's the friction, is when you're going to give something that someone's got and then take it away from them and give it to somebody else. It's always going to cause some level of conflict. And unless we do that in a way that is both sensitive but also authoritative, then I think that will be really challenging. I think in the world of kind of investors for innovation, bit of a different kettle of fish. I mean, they are very money orientated, but we've seen within women's health and femtech huge potential, but really hard for our female founders to actually get funded through various investors. So quite a strong current still exists that's, around sexism and misogyny, even for female founders who want to do something in women's health, by women, for women. So there's a lot to do. But I have seen a lot of green shoots. I mean, I think maybe 4 years ago when I started talking about this, I think people looked at me like I was mad. And now I go into rooms and I hear other people, regularly talking about equity and bias and what are we going to do about it. So I think there has been a huge change in quite a short period of time. But where I'm not seeing the pace of change is probably at that much higher level, which is around the institutions and around national policy, then coming down to regional policy, that leadership piece. I think that's going to take a bit more time to get that right. And moving it from being tokenistic. So when does the big funding come for Black health? That's my, I had that question said to me yesterday at a Black entrepreneurs event, because at the moment it's small bits of money. So it does feel quite tokenistic. So I think we are at the start and I'm excited about the future. And I think that, as I said, there's something around this kind of collective action of lots of like-minded people coming together to solve some of the, the wicked problems that we've got.
And I'd like to move on now to talking about some of those really tangible things that people can draw on, those tangible resources. And MaryAnn, I'd love to hear a little bit more about the 10 principles for health equity, which I know that you've been championing within your organisation.
So my background is I worked in acute hospitals, A&E, worked clinically, then moved into sort of medical leadership, again, sort of an acute focus, and then became really interested around public health and in particular population health. And so when I moved into health innovation, it was very from a kind of a commercial and industry perspective within health innovation. And I really felt there was a need, particularly with the formation of the ICBs, to have a much more population health lens on everything that we did. But we needed a framework in which we needed to kind of operate, because I think there's a lot to be said about discipline and consistency and having a standardized approach to things. So the how we can do it differently, but having a framework in which to follow, both internally as a health innovation network, but also for our partners who sit within industry, academia, NHS and social care. So being able to kind of advocate for that on a bigger scale. So that kind of develops the 10 principles around health equity. I also thought it was important to include sort of two other key areas, which at that time were quite underdeveloped. So one was around digital exclusion, which we've talked about already today. But 4 years ago, we weren't really talking about digital exclusion. So I think it was something that needed to have quite specific oversight of in terms of what we were working on around the Health Innovation Network. And the other one was climate change. So thinking about climate change, not just from kind of a net zero perspective, but thinking about adaptability, preparedness, much broader look at, the impact of what we're doing in innovation. I think that's now with AI really come to kind of the fore, which wasn't my intention at the beginning, but I think it was to encompass what was likely to be coming down the line. And then the third element that was probably a bit more unusual was about place. And it was before we'd kind of gone into that place-based care. But I think it was pretty obvious sort of 4 years ago that we were heading towards wanting to be able to deliver healthcare to people near where they live or in their home. And so how do we start to think about innovation in that space? So I think we have a very medicalized, patriarchal, hospital-centric system. Mm-hmm. And how do we, within innovation, really turn that on its head and think about it from a patient and community perspective? So happy for people to look it up. It's online. It's free for everybody. There's a couple of toolkits to help people actually implement it into their daily practice. And, I hope it's helpful.
And we will certainly put a link to both the 10 Principles for Health Equity and also the Innovators Toolkit and the other toolkit that you have as well in the show notes of this episode. So we'd encourage people to check that out. And just from your perspective, if we think now about the research space, are there key resources that you would point people towards if you are working in that space and you're really interested in enhancing your approach to equity in the work that you do?
I mean, there are many resources. There are, you can go and look at the World Health Organization has principles with regards to AI development. There are also a variety of those types of guidelines that exist. You've got a bunch of stuff that falls within the frame of responsible research and innovation, so RRI. If you go on the website for RRI, you can literally filter through different types of things and they'll give you some pointers, and that will be everything from how do you do proper involvement and engagement in research all the way through to this is data sheets for data sets is one of the big ones. Like, can you describe what exists in your data before you do it? There's a load of stuff with regards to algorithmic auditing, and how do you do that from an ethics-based perspective? So how do you make sure that your research project is auditable, essentially, and that we can go in and look at it? That also means, doing things like making sure researchers are sharing code and looking up things like that. There's a really great guide called The Turing Way, which was originally produced by Kirsty Whitaker at the Alan Turing Institute, but it now has a whole community floating around it. And that's about responsible and reproducible research, specifically database research that has a bunch of tips. But I think probably the absolute biggest thing is think about what questions you're asking. We have, and this very much comes back to picks up a bit on what MaryAnn was just saying, most research, and I'm speaking about my own people, so I'm allowed to be critical, will go, what data exists and what can I find on this data? And because we tend to follow that model, most data exists in the health space that has come from a clinical interaction, and that therefore means it's based on a one-to-one clinical interaction with this one person and this one person. Most health doesn't arise from that, and most inequities do not arise from what is happening between a clinician and a patient in the interaction room. Some of it, yes, but much more of it is structural. And so I think what we should be encouraging researchers to do is ask harder questions. So what is the question that's actually really difficult to answer that we haven't been able to answer before? Now we have all this new tools and data and capacity. Maybe that's what we should be doing. So instead of modeling who is going to be most at risk of type 2 diabetes in this particular location, start asking, why does town A versus town B have a higher level of incidence of diabetes? And then go, what do we need to do about that? And I suspect if you do that, you will get far closer to reducing health inequities than trying to just do personalized risk stratification all the time. But that is what is encouraged because that's the easiest thing to do with the data. And this comes back to our point with regards to funders, because funders can pull that lever.
I think that's such a good point there, Jess, because I think that with health, health innovation and research, we're riddled with taking the easy option, the easiest. And I think we're all there to try to do our best, but the system is the system, isn't it? can be really difficult to want to do something differently, and it can, be really hard sometimes. And I think that example you said, Jess, is exactly where the thinking needs to go, which is completely thinking differently about the problems that we've got. We think in a very linear, task-focused, the way in which we even deliver care is extremely task-orientated. We do this and, we rarely kind of go in with a much more holistic approach. And so I do think that both with innovation and research, we need to start looking at those problems much more differently. And I think we're trying to bring different minds together, because I think we can, as I sort of mentioned before about groupthink with leadership, it happens just anyway. We like-minded people get together, but actually sometimes we need people from different sectors, different areas to start to realise the art of the possible and have those conversations. And as a health innovation network, we're quite one of the things we do really well is the partnership building across various different stakeholders. And I think a few years ago, and it's still in parts of the NHS now, even just working with commercial industry and different sectors was just not the done thing. And now I'm starting to see people actively come to me to say, what are other people doing? What's aviation doing? What's transport doing? Oh, what farming? I heard this on the radio and they're doing this. Do you think there could be something we could do, in terms of health? I think people are much more open to starting to think quite differently about partnerships for health and thinking about it as a much bigger and more global concept than we were a few years ago. And so it makes me very hopeful.
Well, I think that's a great note to end on, with a really interesting challenge and a vision of the future of more transdisciplinary working. So all that remains for me to do now is to thank you both so much for your time and for joining me today. Thank you, Jess, and thank you, MaryAnn. Thank you for tuning in to this week's episode of the Equity Charter podcast. Don't forget to rate, review and subscribe to the series. And if you'd like to know more, go to our website at www.equitycharter.digital. You can follow our page on LinkedIn, join our community of practice, and you can also contact us at hello@equitycharter.digital.